Hello, good morning. I'm Ashok Kurokode, consultant rhinologist and anterior surgeon from Winchester and University Hospital, Southampton, UK. I welcome colleagues from around the world on behalf of organizing team to the second day of inaugural Winter Global Rhinology and Skull Base Surgery Webathon. Global Rhinology Network is a non-profit organization with a mission to foster surgical education in rhinology and skull-base surgery. We have successfully hosted annual multi-center live surgical webcast, The Lioness, since 2014 in collaboration with Lion Foundation. Thousands of surgeons from all corners of the world have benefited from it. More than 2,000 surgeons from 110 countries have registered for GRACE 2020. We had hugely informative and engaging 15 sessions on endoscopic sinus surgery presented by eminent rhinologists and skull-base surgeons on day one. We'll be having similar sessions today focused on anterior skull-base surgery. This event is hosted at the Global Telemedicine Studio of Professor Wilco Grolman in Utrecht, the Netherlands. It is supported by Medtronic and Karl Storz.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
And then can I request Professor Chemeko from Ankara to take over the further hosting and question and answers. Thank you.
Hi, Professor Chemeko, how are you?
Oh, thank you very much. So nice to see you again. I hope we can see each other in person. Please go forward with your presentation.
Thank you very much. Yeah. So, can you see my screen, please?
Yes, we can see it.
Okay. So, thank you very much, my dear Professor Ricardo Corral and Professor Miko. It's a great honor and pleasure to be here talking in this very prestigious forum on a topic which is very close to my heart, giant fibro-osseous lesions of the paranasal sinuses. So I'll be sort of more clinical rather than more theoretical. Just want to say that I'm heading the Asia Pacific for the neurosurgery, neuroendoscopic department. And of course, due to Corona, long time since I have been around. And I hail from a city called Trichi. This is a city called City of Temples. And it's in the south of India. And it's just a small place in India. So let's go on to the topic without much ado. The topic is a giant fibro-osseous lesions of the paranasal sinuses. And basically, if you have a very big tumor, that's maybe an osteoma or ossifying fibroma or a fibrous dysplasia, which is very, very big. The dilemma is whether to do it external or to do it endoscopic or to do it with a combined approach. Now, let us see if we can tackle it endoscopic, some giant tumors. That's what we're going to discuss right now. So let's see this tumor. Imagine that this is actually an osteoma arising from the frontal sinus. Would you do it endoscopic? I'm sure that nobody would even attempt doing this endoscopic. In fact, he came with double skull, 2 skulls. And this is the kind of cases which we see actually in India, having huge osteomas and huge, ossifying fibromas and things like that. So this is what I'm going to present. This I did external approach. And of course, this is not the topic of today, but I just want to tell you that we have a lot of cases like this where we have to do an external approach rather than to do an endoscopic approach. So I think we should be open to doing both external as well as combined approaches when it comes to the the question of giant osseous tumors, really giant osseous tumors. Look at this tumor. It's such a big tumor involving the sphenoid sinus going on to the middle cranial fossa and involving the carotids here and the patient present with blindness. And you can see that this huge tumor, of course, is the kind of tumors which we are talking about today, and not tiny osteomas or tiny, fibrous dysplasias. So we did this endoscopic, and we are going to see the whole presentation, which is going to revolve around this. Now let us go to some case presentations because I want to be more clinical, and just want to show you that this was the case which presented to us with proptosis headache. We'll start with the little small tumors, then go for the big tumors. These are the small kind of tumors, a big osteoma, but inside the ethmoids going into the orbit. And you can see that what we did was, of course, endoscopic for this case. And you see one big tail here going right inside the orbit. And I do want to tell you that if you have an osteoma like this, the most important thing is that never try to remove the osteoma in one piece, because that is going to be a problem, removing it from the anterior nares. Even though you can actually get it out of the nose, you can't get it out of the anterior nares. So what we actually do is to completely cavitate the whole tumor, try to make it into pieces. So that is the whole principle of osteoma surgery. And I do what is called the central cavitation, and completely cavitate the tumor and make it into small bits so that we will be able to remove the tumor through the nose. Of course, we've had some cases where a little bit of the bigger tumor just fell down into the nose, and we have to make an external alar incision to take it out. So sometimes I've seen some people actually doing a lateral rhinotomy just to take that tumor out. So these are the cases I really warn you, actually never try to chisel it out and take one big piece, because it's not going to come out through the small nostril. So what we do is completely central cavitation is exactly what we're trying to do. See where the attachment of the osteoma is. Of course, this is attached to the ethmoids, and you see here, this was going into that is the Takahashi forceps. I'm trying to wriggle that tumor out of the orbit. I'm doing a cross-cord approach. You can see a septal window here. My instrument is coming out through the other nose, and I'm trying to, dissect the giant tumor from the orbit. Be very careful, because you're not going to injure any muscles there. Of course, there is no attachment of the osteoma inside the orbit. So you see how we are trying to dissect the tumor from the orbital contents without much pull on it, because sometimes you might have some fibrous adhesions, and that can cause some extraocular muscle palsy or paresis or whatever. And so I'm trying to dissect it very gently and slowly. And once you do that, you see how there is no pull on the left hand, only the right hand is dissecting. And that is very important. Never try to pull at any tumor from any vital structure, like maybe the skull base or the orbit. So this could be easily wriggled out through the nose, and that came out in 2 pieces. So this is how we did this case. Let us go on to some fibrous dysplasias engulfing the optic and the carotid artery, and how do we deal with it. Let's see this case. Imagine this huge tumor going and encroaching onto the carotid artery, and the patient also presented with diminishing vision, had several surgeries before. You see that they had done a lateral rhinotomy, both sides, tried to approach this tumor. And this is the problem. Actually, what generally we face is that multiple revisions, surgeries, they come to our center after the 6th surgery or 7th or 10th surgery. And we're going to see how we do this case endoscopically. And that's a pre-op of the nasal cavity already operated. And you see that this view after removal of the cyst, there was a cystic component as well. I aspirated the fluid content and then started elevating it from the anterior part, slowly drilling on to the skull base. You can see the skull base being drilled off. And what you can see here is the cribriform plate, the panoramic view of the frontal sinus. The draft 3 has been done. You can see that this is the site of attachment. That's the optic nerve. You're trying to release the optic nerve on both sides. You can see that's the optic nerve. That's dura at the level of the planum. The optics are both sides. And you can see the supraoptic recess. That is somehow very well developed in such tumors which are encroaching onto the optic. Actually, then we'll have to drill that out and release the optic. Now, let us see some other tumors like the cementifying fibromas. So these are another variety. So we have basically 3 varieties: the osteomas, the ossifying fibromas, the fibrous dysplasias, and in that you might have a lot of sub-classifications. You have the cementifying fibromas. To see how what we are trying to do is to drill at the level of the dural plate. Basically, there is a common misnomer that if you operate on an ossifying fibroma or a cementifying fibroma, it recurs. Actually, in my experience, the recurrence rate is very less. The reason is because what we do is we completely remove all the attachment to the dural plate. We, in fact, completely bare the dura, and if it's attached to the orbit completely, see that's the orbital decompression completely done. And we will remove all that skull base, and then we will reconstruct the whole skull base. And if we do that, to our knowledge, the recurrence rate is less than 10% in our hand. So that's the optic. That's the the whole cribriform plate, which is going to be removed completely. And you can see that every bit of that tumor is removed till we see the normal bone. And you can see that's the optic, the carotid here. That's the carotid pulsating, very, very beautifully seen there. And you can see that this is the optic again. And then we try to, so we didn't have a CSF leak in this case. It's a very nice thing that we don't have a CSF leak. And you can see, let us go on to this osteoma, which is attached to the skull base. So you can see it's attached to the skull base, a very broad attachment to the skull base. And how do we operate on such a case? So again, the principle of cavitation, already operated 6-7 times before. Try to do a draft 3. So that's how we usually plan the case. First of all, identify the first olfactory neuron. A very important thing is that I always advocate that go from the normal side to the abnormal side. Never operate on the osteoma and go towards the normal side. Use the normal side anatomy, use the posterior table of the frontal sinus, and then go to the abnormal side where the anatomy is totally gone. So what we will do is try to cavitate. In such cases, navigation is very useful, but somehow we have navigation, but we generally tend to, go by 3 important things. Number 1 is the sound of the drill. The sound of the drill is very, very important. If you have a very high-pitched noise, that means you are near the dura. Number 2 is when you see the normal mucosa, there's a small mucosal layer which is actually there, and that is the color. I see the colors change. And the third is you will have a very, very clear-cut feel. The feel. You will have that feel, a small feel, and also a small dural bleed. If you touch the dura, you might have a small bleed. So these are some very important features which you see that the blood vessels, you can see the color. Change in color. I told you the change in color is very important. And also there you will have a high-pitched noise. So these are some cues. Of course, navigation is very good, but what I'm trying to do now is to cavitate that part of the osteoma, because you see that we are not able to get it out of the nose. This is the problem. So if you have a big piece, trying to get that out will be a very big issue. Trying to pull that, you might have to take some incision. Of course, we have generally not tried to done any incision in the ala so far. But the principle is try to see the fight between, I made a small like a ear lobe and then try to pull it and then it came out. So you can see that this is the kind of complete removal. You see the draft 3 and then you can see that the orbit completely and then the dura, you can see the pulsations. This kind of complete removal is what I always advocate in cases of osteomas, especially for ossifying fibromas. So this is how it heals. So this is a 6 months post-op nasal endoscopic picture. You can see that this is the healing, very, very beautiful. Of course, there will be some crusting for at least 4 months and then it will stop. Let us see now the osteoma involving the anterior table. So we have had cases where the osteomas involve the anterior table of the frontal sinus. So how do you approach a case which is involving the anterior table of the frontal sinus? So I'm going to show you this. This is going to be a combined approach. You see, that's the osteoma going right and going, that's the anterior table. Now, what we will do is we are planning for a combined approach in this case. So what we will do now is first endoscopic approach. We will try to do it endoscopic. I'm trying to chisel it out. Of course, this is not the right way, but just to show you that it's not the right way. What we will do now is to cavitate. So start cavitating the osteoma. And once you do that, of course, you're going to do a draft 3 in this case. And then what we do is we do an osteoplastic flap. So we will try to rise up bicoronal flap. And then what we will do is see that we have removed the tumor completely from the frontal sinus, go right till the posterior table. And that's from view from above and below. You see that? I'm removing the osteoma from outside. So this is how, and how do we reconstruct? Because the whole anterior wall is involved. So we actually keep a titanium mesh. So this is how we've done around, I think 6 or 7 cases now, 6 cases already. And most of them are very advanced, and there is a huge frontal bossing, and the whole anterior table is gone. So once the anterior table is already gone, then we cannot take a template. It's the frontal template. You see that till the dura we have drilled, and then we take the pericranial flap. That's a pericranial flap. To me, I think the best flap for a giant osteoma is a pericranial flap. So I strongly recommend that people should use a pericranial flap, and you can see that this is the pre-op of the patient, and that's the post-op. We have used a mesh there, and that's the post-op completely removed osteoma, and this is how we actually follow up the cases now. The patient is around 3-4 years now, and well, let us see this case. This is a very interesting case which actually presented the history of proptosis. And our neurosurgeon, it actually went to a neurosurgeon. He said, we'll do a transcranial approach. I said, let us do an endoscopic. Let us try an endoscopic. You see this tumor, a very, very interesting tumor going into the frontal lobe, completely into the frontal lobe. And this was actually a summer-matus variant of you can see that that's a summer-matus variant. And you can see it's going right inside the cranial cavity. And we did that endoscopic, completely endoscopic. You see how we did that? We will just try to open up the tumor, and you will see the cystic component. Some of them have cystic components as well, and they are summer-matus varieties. And you can see that this is not CSF, even though it's pouring, that's not CSF, it's just the content. And then we do what's called the binostril approach. And what we do is we do extra arachnoid dissection. So first is going to be a centrifugal approach, and then will be a centripetal approach. You see that I'm separating it from the dura. This was done with a HD camera long before the S-Spice camera came. So you can see the dural venous sinuses. That's actually the arachnoid villi. You can see very beautifully the frontal lobe completely, and then we reconstructed this case. And the neurosurgeon was with me, but though we did it endoscopic. You see that we are. This was done around, I think, 8-9 years before, 2010 or maybe 2012. You see that's a post-op. You can see the post-op completely removed tumor right till the anterior clinoid process, and this is removed in toto. So this is actually the kind I'm talking about. See this case, very, very interesting case. I hope many of you would have seen the movie Avatar. This is a very famous English movie. And actually the eye, you can see this is actually a girl. With the permission of the girl, I've taken it. Imagine that this girl has been operated 10 times before, and she was holding her eye with her hand. Imagine that the eye was held with her hand. So how do we operate? So I decided to do it endoscopic, completely endoscopic. And imagine this is going to be done endoscopic. I'm going to show you how we do it endoscopic. So these are the kind of, see the tumor. So we're talking about these kinds of tumors. It's completely 10 times operated, and they have not yet touched the dural plate. So basically it recurs because you don't remove it completely. And you can see that this is complete excision of the dural plate. That's immediate post-op, and the eye completely went inside. See here, this is the 15 days post-op, the 6 months post-op, and the incision has been given by the previous surgeons. All of them have tried external approaches, and you can see now this patient came 10 years post-op. This is 10 years post-op, and see this patient. So happy patient, 10 years post-op, and this is I think around 13 years already now, and she's rid of tumor, completely rid of tumor. So let us now see some very interesting cases. Let us see that this case presented to us where a 28-year-old male with a headache and history of fibrous dysplasia. And you can see that this is actually diminishing vision going around the optic nerve. So if you have sort of a ground glass appearance like this, then you suspect a fibrous dysplasia. Of course, very common in females, and if it's above the puberty, we generally tend to do only a cosmetic correction. But sometimes what happens is that it involves the optic nerve and it compresses on the optic. Imagine this is the sphenoid sinus and complete bone in the sphenoid sinus. Where do you get the anatomy from? To me, I think the best way to get the anatomy when you're lost, of course, is navigation, but the best is to get the plenum. So I always advocate that go up, get the plenum, and from the plenum, get the optics. So this is the very important carry-home message which I want to convey to all the juniors who are operating on a completely distorted sphenoid sinus, whatever tumor, osteoma, fibrous dysplasia. Go for the plenum, get the plenum, and then get the optic. You will get the optic, you will see the small vessels over the optic nerve, and then you know exactly that you are on the optic. And you see how I am separating that tumor from the optic. I got the plenum completely. I'm getting the optics on both sides. I'm getting the tuberculum. So get the plenum, get the tuberculum, and then go for the carotid. So the carotid should never be the first to address. So let us now go and see what we're doing on the, see the optic. Very beautifully seen, getting right on to both the optic nerves, and that's a supraoptic recess. I told you very well. The anterior clinoid also gets involved when such tumors, and then you see I'm drilling right on the carotid. So that's going to be the MOCR level. That's the medial opticocarotid recess, and from there I will come down onto the sella. So that's how we will try to make the anatomy from no anatomy to complete anatomy. We will try to drill all that. Imagine these cases, sometimes we use the navigation, but when we operate outside in some other countries, we generally don't use the I have operated at least 6 cases in Germany, I think with Professor Gero Strauss from Leipzig. So I visit there every year, and every time he gives me a giant osteoma, and I'll have to operate it, of course, with the navigation there in Germany. But then this is a kind of cases we operate in India. You can see that now I'm getting at the superior intercavernous sinus. That's the carotid being delineated. You can see the carotid. Now I'll use my Doppler to look at the carotid. You can see very, very nicely. This is, see the anatomy. Now when you drill on the carotid, be careful that you know exactly the anatomy of the carotid course, the course of the carotid. So I'm doing just below the tuberculum and getting at the sella. So first the plenum, both the optics completely decompressed, and then once we do that, I'm removing the tubercular struct there. That's the tubercular struct, and once you do that, you come down. So the main idea was to decompress the optic nerve in such cases. See that? That is the anterior clinoid, the anterior wing of the anterior clinoid process. See how nicely the optics have been completely decompressed. And then of course go for the sella. All that is then you put the Haddad flap. Now I'm just going to finish off with one case. How much time do we have? Dr. Miko, Professor Miko, how much time do we have, please?
I think we are good for at least 15 minutes.
Really?
Okay.
15
Let me go with the video.
Ashok? Okay,
Thank you very much. Thank you very much. So let's see this case, a very interesting case of a huge osteoma, and what we are trying to do now is not an osteoma, I'm sorry, ossifying fibroma. And you can see that we are trying to first get at the frontal sinus. This patient had a complete involvement of the skull base. So again and again, my secret, or whatever I call, is that always try to remove the dural plate. If the orbit is involved, remove the lamina papracia. Unless you do that, this patient is going to have a recurrence. So this is very important. I'm doing of course, a draft 3. Now you can see I'm doing a draft 3. And one other simple technique is go from anterior. So you have a beautiful cleavage plane from the nasofrontal beak, and from there you can just work your way. So I think the most important landmark, which I again and again try to insist, is the skull base. So the skull base is, to me, the most important landmark. I'm trying to take off from the frontal sinus, and I'm trying from anterior to see the ossifying fibroma, very, very clearly seen. And I'm now trying to go right along the frontal sinus, the posterior wall, and I'm just trying to take off all that ossifying fibroma from the skull base. And you can see what I will do now is to completely Okay, now that's actually going towards the orbit, and this is the skull base orbit junction. You can see that beautifully seen there, very, very nice. And you can see the dura coming into view. And once you get that, then you know that you have removed the tumor completely. So the idea of telling that it's going to recur, I am sorry, I might not be able to agree with that, because if you can completely remove that, there is no chance of recurrence. There is maybe yes, but if you leave behind a little, but then it's better to remove it at first shot, one go. So that's you should be radical about ossifying fibromas. Ossifying fibromas are really, really notorious for recurrence, and generally in children, and we have seen that mostly in children. And now, you know, taking it from the dura. So of course I have a pericranial flap. Always I believe on pericranial flaps as a workhorse. This is something which is to us, the first thing I would like to see is whether the forehead has been touched, any transcranial approach has been done. So you see here, that's the dura completely exposed, the frontal sinuses, and that's a 30-degree view. And once I go back, it's going towards the planum. I've completely decompressed the optics, and that's actually the sphenoid sinus completely. And then what we do is we reconstruct this patient's skull base. The first layer we keep is Surgicel. So that's about reconstruction, how we reconstruct. We keep a lot of Surgicel. I love this as the first layer. It acts like a nice, you know, sticky material. And then the next layer I would like to do is a fat. Fat is a lovely material. Sometimes we use Duragen, and that will be placed over Surgicel for me. So this patient maybe was operated outside India. I'm not very sure, but this is actually the fasciolata, only fasciolata. And then we believe in again and again the pericranial flap. Let us see how we do that. So we bring in what's called a window, a frontal window, a small frontal window, and you see the pericranial flap already which has been harvested coming down into the nose, and this will actually cover the whole of the skull base till the level of the maybe upper or the middle clivus, mid clivus. So this flap is a very robust flap, and it's really fantastic in case of giant ossifying fibromas or giant osteomas involving the posterior table of the frontal sinus, and you are scared of getting a CSF leak. I think you will have to think about see the pericranial flap now. Make that frontal window very well. That's the nasofrontal window, and maybe call the Marcos window. We'll call it the Mecos window hereafter. So that'll be great. So you can see that the Mecos window has been made, and you get the pericranial flap inside. See how beautiful it's covering. This is actually, this will never fail. Once you have a vascularized pedicle flap, very less chance. These patients, the CSF leak rate are very, very low in our center. And again, I insist that we have, that's a post-op scan. You can see how the whole of the skull base is completely removed. You can see that's a normal bone. There is no, and you see that this is the complete removal of the bone. You see both sides, the lamina has been removed on this side. You can see the lamina completely removed. And this is what I always say, go in for a very radical approach at the first go. And if you do that, so how many cases have we done? Around 89 cases, of course, not yet published because we, corona and many other things. So osteoma around 51 cases, ossifying fibromas 26, and fibrous dysplasia 8. So let us go on to the conclusion. The first priority is to secure a biopsy. Take a biopsy. Of course, the CT scan will give you a very good idea. The goal of treatment of ossifying fibroma should be complete surgical removal at the first attempt. So this is very, very important. The surgical approach, the location of the lesion, of course, if it's going to involve the anterior table of the frontal sinus or involve the other parts of the skull, it's better to go in for an external approach. So most CSF leaks can be repaired intraoperatively. Of course, use the pedicle flaps, carefully weighing the risks of complications such as optic nerve, carotid injury. Surveillance for tumor recurrence seems prudent in all patients. So ask them to come for follow-up, regular follow-up, and I always ask them to come every 3 months and maybe a year. So I think many of you might be knowing that we have published several books. You can keep reading all that. I published it with Professor Dharamveer Sethi. In fact, most of the forwards have been written by Professor Ricardo Carrao, and I have dedicated most of the books to Professor Ricardo Carrao. He is my teacher. If at all I'm doing something, it's because of 3 people I have to mention. One is Professor Ricardo Carrao. Second is Professor Amin Kassam, my sweet dear professor, and my third very important teacher is Professor Daniel Prividello. So 3 people I learned from. again and again, I keep mentioning this in almost all the conferences. Of course, we've written chapters in so many neurosurgical textbooks. Let us conclude with just one important video. So this is going to be the conclusion video. You can see that this is the osteoma. You're the surgeon. Try to break the osteoma. So into pieces. You're going to break that osteoma, but this is going to be the carotid. So don't just have to see that you don't injure the carotid or the optics. And if you do that, then you're causing harm for the patient. So this is my final, conclusion, saying that preserve all the vital structures, but take off the ossifying or whatever, osteoma or whatever. So gracias, thank you, namaste, and thanks for this opportunity.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise, we're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super-speed USB, or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more, do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.
Thank you very much, Dr. Janakiram. Wonderful cases. Really, they're.
You have to unmute, Professor. Yeah. Thank you. Yeah, I can hear you now.
Okay. You're so right in your comments, especially about the lobulations within the orbiter, for example, when you're taking out. There might be some attachments around the lobulation, so you shouldn't really be putting out. So I'm just looking if we have any questions from the attendants. So
I can see one question. Do patients suffer from empty nose syndrome? This is a very good question by, can I?
Yes, please. Yes, please. These are for you.
So this is from Professor Mohammed Khan, and he asked me about empty nose syndrome. First of all, the topic of today was giant ossifying tumors. So we have huge tumors occupying the whole nose, and there is no. You cannot take the tumor without cutting the middle turbinate. You cannot preserve everything and remove a huge giant tumor. This is just not possible. So I think, your question is right. Do they suffer from empty nose syndrome? In our experience, I think the most important culprit producing the empty nose is the inferior turbinate. So if you can preserve the inferior turbinate in all the cases, this is something which we have seen. In fact, even in skull-based tumors, I'm sure Professor Karau and Professor Daniel Privedelo would give their experience on this. If you preserve most of the inferior turbinate and if you do a ACFR, these patients have crusting. But generally don't, they settle in 6 months to 8 months time. So this is our experience.
There is another question from Dr. Marco Castelli asking what is the recurrence rate for fibrous dysplasia removal, but you already have answered complete removal in your hands, I guess, but would you like to comment?
You're asking me to comment? Yeah. So
Yeah.
fibrous dysplasias are different ball game. They are not like ossifying fibromas. Most of them actually are from young females, prepubertal, and they keep growing. And we do more of a cosmetic, most of them involving the maxilla, and we do a cosmetic removal. Leave behind a little bit, but after the puberty, it stops growing. But there are some cases where it involves the optic nerve, the carotids. Those cases, we just go inside and remove it completely. So that's my answer to that. Yeah.
But do you wait till the patients get any symptom, or do you go right?
Absolutely. Unless the patient presents with diminishing vision. To me, I think there is no role. We have had so many cases for follow-up. Just observation, there is no point in treating a scan. You have to treat a patient. There is no point in treating a finding on a scan unless the patient presents with a particular finding. Even we have seen so many osteomas of the frontal sinus producing no symptom at all. But there are some, even the small frontal osteomas, which I didn't present here, can actually be in the frontal recess and produce frontal sinusitis. Even though they are not big enough, they will obstruct just the frontal recess, producing intense headache, frontal sinusitis. These are the cases I operate. But there are some big tumors inside the frontal sinus, not occluding the outflow tract, then I generally don't operate. I just observe.
Okay, thank you very much. I see no more questions, and for the sake of time, may I thank you very much. It's great to hear your fantastic cases once again. Congratulations.
Thank you.
My teachers here. Thank you so much, sir.
Now,
thank you. Sorry for interrupt, Dr. Miko. I just want to say some words. Congratulate Dr. Janakiram, a beautiful presentation, and thanks for mentioning our names there. We're happy to, disseminate the knowledge. Thanks so much.
Thank you, Professor.